all the speakers and co-instructors to please come on the dais. Dr. Ashok Sharma is going to join soon. Professor Amit Gupta, Dr. Shweta Agarwal, Professor.
Sitting
Yes,
here, and
I think Dr. Amit, Professor Amit, please. And Professor Arun Jain is going to join. Professor Chintan Malhotra is here. Professor Ritu Arora will be joining. Professor Vanathi will be joining, and Dr. Revati, please. Yeah, please come.
well, I'm sitting on the.
No, it's okay. You come here. Yes. So this session is contours of corneal perforations, and should I start first? Then tectonic patches and matches.
Yeah. Whatever way
Yeah.
you like.
Okay.
So good afternoon and welcome to this course. We'll start right away so that we are on time.
We can wait 2 minutes. This is good.
I think if you can just project the other side. Yeah. So I would, it's time, and I would request our first speaker, Professor Radhika Tandon from RP Center, to be delivering her talk on tectonic patches and matches.
Professor Chintan. Good afternoon, everyone. This is the instruction course on contours of corneal perforations, which is an important area. And this is something which people in the periphery may encounter. I'm talking about patch grafts. Now, tectonic patch graft basically is to reinforce and support a weakened cornea. It could be a small patch because it's a small or localized area. That's essentially the difference between a patch and a full graft. Generally, one can use either cornea, amniotic membrane, or tenon. Sometimes one may need to use sclera. And of course, we have the option in a futuristic manner of using biopolymer or bioengineered tissue. The important thing is it's a weakened cornea which needs tectonic support, but one mustn't forget that there is an underlying disease process and that must be investigated and taken into account. There could be thinning, melt, a perforation, and a decimetal seal, and this is an important surgical technique because it restores the stability and function, and sometimes that is all that is required to be done. So understanding the indications, techniques, and outcomes enhances clinical practice. So there's basically a clinical evaluation, investigations to look for the cause, surgical planning, not to forget systemic disease, comorbidity, and medical management. So medical therapy could be local or systemic depending upon the etiology. The surgical procedures, there'll be the tectonic procedure to start with, then a restorative procedure later on, and then prophylaxis and follow-up. Regarding topical treatment, if it's an infective etiology, then one would give the antibiotics and anti-inflammatory, cycloplegic, and also medications to promote the healing. Dr. Shweta, please come on stage to the dais. Yeah. And then adjuvant therapy, which could be anticollagenolitics such as medroxyprogesterone, tetracycline, doxycycline, which is often used, and N-acetylcysteine. The medical treatment systemically would be antimicrobials, anticollagenolitic to promote collagen synthesis, steroids, and immunosuppressive depending upon the indication. So now I'm going to take you through a few case studies and experience based on our publications and our evidence-based review. Few clinical notes, look for the etiology, extent, comorbidities, and systemic conditions, and plan the medical therapies. Not that you have to rush for surgery the moment to see the patient. You can start medical therapy, stabilize the patient for 2 to 3 days, improve the condition, and then proceed for surgery. And then, of course, rehabilitation to regain vision. Just to give you a few examples of case studies, this is a 45-year-old unmarried male who had a history of high-risk behavior. He was a chronic alcoholic, and this is a condition of both eyes. There were iris nodules, pupillary membrane. There was this area of corneal melt. Patient was aphakic with no history of previous surgery. There was scleral nodules, nodular scleritis. So there was a perforated lesion with necrotizing scleritis. The ocular features predominantly, because it was bilateral, there was accompanying scleritis, anterior uveitis, and aphakia. So we did a thorough systemic evaluation, and that on dermatological consultation, there was a genital ulcer, which was single oval shape, painless, and indurated. The vision was 5/60 in the right eye and hand movements in the left eye. So it turned out that the patient actually had syphilis. I'm not sure why the post-treatment picture is not showing. The patient actually turned out to have syphilis and was treated medically and resolved. So that one need not straight away go for surgery if one is not sure about the systemic condition. This is another example of a 47-year-old male with Sweet syndrome presenting with sclerokeratouveitis and secondary glaucoma. And he actually worsened with topical steroids, and the diagnosis was confirmed to be tubercular in etiology. As you can see, it worsened with steroid. There was progressive necrotizing scleritis. And then with medical treatment, the patient resolved completely. Here's another example of a patient who had 26-year-old female. She had this whitish opacity, diminution of vision. There was a bilateral hypotony with low intraocular pressure and disc edema. She had hypophysitis, and she required surgical treatment because of the persistent hypotony. But being a case of corneal perforation, I'm not showing the surgical video for this, but the patient did well. So progressive hypotony, maculopathy, she had the patch grafts done, and the patient recovered. This coming back to the syphilitic patient, somehow the slides got mixed up, but he had the ultrasound showed that the lens had actually fallen posteriorly, and he was treated with fortified antibiotics and anti-syphilitic agents. And this is how the patient recovered completely with 6/9 vision in the right and 6/60 in the left eye. Now coming to the actual surgical technique. So here we have an example of surgery. You can do the surgery under local or general anesthesia depending upon the age and the indication. You have to mark out this is a very extremely old video. You have to mark out the edges, measure the diameter. Usually you have to do a patch graft if the lesion is more than 4 millimeters. Below 4 millimeters, it is amenable to glue. But if it's more than 4 millimeters in diameter, then you do need to do the patch graft. In this case, a donor cornea is being used, and there are various techniques. So either you try to free the iris adhesion, form the AC, and then do the surgery, depending upon how long it has been exposed. The other way is that you just do an onlay graft, let it integrate, and then you can release the synechia at the end of the surgery, depending upon how stable it is, whether the patient is phakic or not, and what is the space in the AC available. In fact, once you suture it, you can make a small stab incision and then inject viscoelastic, make some space, and then free the iris. But beware, if it's an extremely large area, then the iris may bleed. It's very necrotic, and there can be a lot of hemorrhaging, and even the necrotic iris being exposed already may also introduce organisms inside the eye. So these are all concerns that need to be taken into account. Usually 8 sutures are adequate in such cases, and little longer bite on the corneal side, so it's a little easier to bury. And do try to bury on the donor side. Sometimes that is difficult, and you may have to bury on the host side. And also sometimes people would be worried that now the sutures are coming near the visual axis, so you have to gauge the situation. If you're looking for just tectonic restoration, you can take care of the vision later. And sometimes if it heals well after suture removal, it integrates quite well, and the patient's vision is maintained. This is an example of how sometimes you may have to thin the donor cornea. So you measure the diameter of the defect. You identify the size, and you can thin down the donor cornea posteriorly. So you can do a sort of a lamellar or patch graft, and it can be glue assisted. So in this particular case, fibrin glue is being applied on the bed, and then that donor tissue is being applied and integrated in place. So this was usually it sticks very well, and you can follow this up with either amniotic membrane or even a bandage contact lens. This is the patient post-operatively with a glued patch graft. So customizing the donor patch, as I explained, that you can do a freehand dissection. Sometimes you have to adjust the shape, and sometimes you have to adjust the thinness. You can either do it freehand, or you can even put it on a Teflon block and have an assistant support the tissue, and then you can proceed. So this was sutureless patch graft for sterile corneal melts. It was a concept that we had introduced and published in Cornea in 2010. So assess the perforation, look at the extent, and then you have the various options as I explained before. Surgical treatment, only inlay and optical, and then preoperative assessment and final planning for the surgery. So therapeutic and tectonic role, as I mentioned, and then later on rehabilitation would be required by any cataract surgery or any other procedures as required. And as I explained, photo ASOCT and in vitro confocal microscopy can help to see how is the integration of the tissue. Is not essential, but it's interesting to see what happens to this tissue later on. And you'll also find that for fully opaque cornea, only a small patch has been used and actually does clear up. So don't be afraid of being nearer the visual axis rather than, excising the entire and going for a full thickness PK at first stage. So first step is support the eye and then proceed with the later surgeries as required. Thank you all for your attention.
Thank you so much, ma'am. And I think what you mentioned about not rushing into surgery is one of the most important things. It's important to know when not to rush into surgery. Right. I would like to invite some comments from the panel.
I'm so finally.
No, I think Dr. Chintan has very well pointed out, and the presentation was, just answered everything, where to do a patch graft and how to do, and a beautiful use of corneal tissue. So nothing that really I need to add.
So I have only one question to Radhika, that you said that anti-syphilitic treatment. I have forgotten what are the anti-syphilitic treatment available in current era.
So actually what happened is since that patient had a perforation and there was usually when there's a perforation and we are suspecting an infection, we often do give systemic antibiotics. So we had started the patient on ciprofloxacin, and when the diagnosis came, the patient had already started showing some improvement, and apparently ciprofloxacin can be used. Of course, otherwise the standard therapy is penicillin, but the patient responded well to the ciprofloxacin itself, and so it was just serendipitous. Yes. He had syphilis.
He had systemic also.
Yes. So the oral I'm talking about oral ciprofloxacin because
only oral ciprofloxacin will do.
And he was given yes. It can do it. It is known to. And so the dermatologist said that ciprofloxacin is a drug which is currently used, and it was enough to treat his systemic syphilis as well. And otherwise, yes, normally one would have tried penicillin, but it is one of the agents. Availability is a problem. It's an injectable. And so therefore and syphilis is so rare now, so that, as you correctly said, you're totally nonplussed when you got the diagnosis, and so ciprofloxacin is one of the agents which
no, syphilis is not rare. Recently in America, syphilis is a major concern for military people for last 7-8 years. So syphilis, they are also introducing VDRL or other syphilis test for iBanking system. So it is not not rare, because their military is going here and there and doing a lot of things. So that is the problem. That's why syphilis, again gonococcal infection, the drugs, we know that it is penicillin, but penicillin, you write something. I got a patient, it is difficult to get a penicillin, freshly prepared penicillin eye drop, still required in some of the cases. but it is very difficult to get.
I think
That's
yeah,
why the question.
it may be probably it's the high index of suspicion needs to be kept. The cases would be there, but probably they're not being detected that much. So with that interesting discussion, we'll move on to the next talk. There's a little bit of change. Dr. Ashok Sharma is busy in another session. So we'll have the next talk by Professor Amit Gupta, and he will be speaking about how we can think out of the box and use a smile lenticule for corneal perforations.
Thank you, Chintan. And I think we have so many very interesting talks which are yet to come. But this is something which I started using not a very long time ago. And it was mainly, I think, during the COVID times and post-COVID that we actually started using a lot of smile lenticule because there was a shortage of good tissue. So if you look at the use of biological tissue for managing corneal perforations, it's amniotic membrane or conjunctival flaps, or we have tenon patch grafts and various types of scleral grafts and other corneal grafts. And we also have the tissue adhesives like the fibrin glue and the cyanoacrylate glue. And in times of shortage, we did end up using a lot of scleral tissue to seal these kind of perforations because they are like full thickness, and this was a peripheral perforation, so the graft did very well. With so many smile procedures being done, we looked at the lenticule which we obtained after smile surgery because this is an excellent tissue. It's just a smooth stromal lenticule. It is readily available if you want to harvest it, and it is inert relatively, and you don't really have to go to too much of hassles to process it before you store it or you use it. So, most of the cases where smile lenticule has been used are cases where you could get away with using cyanoacrylate glue also. So, why should you use smile lenticule vis-a-vis cyanoacrylate glue? We know that the cyanoacrylate glue is synthetic, it is pro-inflammatory, it is leads to a lot of discomfort in patients, causes inflammation, and it's just a temporary means till it sheds off. And most important, causes so much of vascularization that sometimes to rehabilitate these eyes optically becomes next to impossible. The smile tissue, on the other hand, is a biological tissue, and it has better tensile strength, provides a stable scaffold for the corneal repair. Classically, how many of us are very used to seeing this kind of a picture a few weeks after applying a cyanoacrylate glue? Look at how thickened the upper eyelid has become. It is inflamed, chronically inflamed eye with just a huge amount of vascularization coming in. Even if you do an optical graft after that, it won't stand a very big chance of survival. Now, this is the first case that I did, and this was an area of thinning, post-herpetic keratitis, and very important here is to create a nice bed with vertical edges because you want to stabilize the smile lenticule there. And once you take the lenticule, you shape it according to the size that you want to seal. In this case, I thought I could get away with just a little bit of cyanoacrylate glue, but ultimately it kept leaking so that I had to apply a huge amount of glue. And the patient otherwise did quite well and healed well. So we went on. I prefer using sutures, and that's what literature also advocates. So important thing, as I said, is to just have spend some time on making vertical edges. In this case, I have undermined the edges, and so that the suturing is much better. And AIOCT is being used, and this often can guide us to how thick is a graft that we need in these cases, and how are we doing. So this patient also did quite well after surgery, healed very well, and went on to undergo an optical corneal transplant with good restoration of vision. So this case of infective keratitis, Dr. Radhika showed in an excellent way that fibrin glue that she used. I tried to use fibrin glue. It doesn't really work every time. It becomes very difficult, and I ended up actually using cyanoacrylate glue in this patient, but he did quite well and it healed. So what are the advantages of corneal stromal lenticule? It is safe, efficient, it is inexpensive, it's an acellular tissue and does not require eye bank setup, and it's a biological tissue, so it's less reaction. And what does the literature say? There are not many studies which are there, but they indicate that in majority of studies there was a maintenance of anterior chamber after the use of smile lenticule. No significant complications, no cases of rejection or no recurrent cases of infection have been reported as yet. The limitations, well, there is a narrow range of diameter of the corneal lenticule. So, you get 6 or 6.5 millimeter lenticule, and therefore it is not suitable for very large perforations. Limited thickness of most lenticules. So, usually 100 to 140 microns, we usually would not go beyond that. So, it may require multiple overlapping of the smile lenticles to give us the adequate tectonic strength required. It requires careful handling of the tissue. And I just reviewed some of the literature. This is important for us to know what other people have done. So basically, one of the initial studies, they used, they did test all the donors of the smile lenticule for viral markers, as well as they have some other studies have noted that they should be free from any corneal and systemic disease or any other history of corneal surgery. So that's what has been noted in various studies. So they have stored, this particular study stored in BSS with the concoction of antibiotics and antifungals to store it at -80. Some people have used Optisol, like we have used Cornisol in our patients. Our people have used 0.9% normal saline, and many of these studies have actually used 10-0 nylon sutures, and I would myself advocate the use of 10-0 nylon sutures when it comes to using the smile lenticule. Most of these outcomes have been very encouraging and positive. Some more studies in a similar way they have noted, and there's only one study where they used fibrin glue, and that was, and these the inclusion criteria was microperforation or lamellar tear. So full thickness fibrin glue, normally it doesn't really give you the kind of strength to seal the perforation. So just a few tips on utilizing the smile lenticule. The donor smile lenticule from patients of myopia correction, at least 5 diopters, preferably 6 diopters or more. And the lenticule is stored in Cornisol. That's our protocol. And we can do cryopreservation at -80 degrees. So to conclude, there exists a significant future potential for smile lenticule to be used as biological tissue or and replacement for maintaining the ocular integrity, especially for small corneal perforations. Corneal thinning also, it does very well in that scenario, averting the need for a therapeutic keratoplasty and its associated complications. Thank you very much. I'll take any questions. Thank you.
Thank you very much, Dr. Amit, for nicely covering the topic and use of smile lenticule. It is a very useful technique, and it sort of adds to the armamentarium of tissues that can be used. Thank you so much.
Thank you.
I would request the audiovisual people to please put the timer.
I have a question. Can I ask?
Yes, of course.
Dr. Amit, I just wanted to check with you. Like usually when it's a beautiful technique, it's like, do not waste what you can save. So, but my only question is, routinely when we do refractive surgeries, we don't ask for a HIV test in the patients, but the eyes that we get and we transplant, we usually do that. So are you in your center asking for an HIV testing before using these smile lenticules, or?
This is entirely optional. And initially, our experiment with smile lenticles initially began with trying to store it properly. We experimented with various techniques and got down to Cornisol, which is all right to store it. But yes, ideally before doing it, you must screen it. But as a routine, it's very difficult to do in refractive surgery patients. But it's a surgical protocol. You can ask them. But sometimes people voluntarily do it. It's fine.
So I have one or two questions on that. One is that how do you use fresh one or a cryopreserved one?
So we are using preserved ones because our
Preserved.
I mean, we are preserving
No, Cornisol preserved.
just in Cornisol,
Not
regularly,
cryopreserved
just like a
like
regular
minus-
graft. We are not storing at -80.
-80 you are not.
We can store in Dalbecos at -80.
Okay.
We have done that also.
Okay. Second question is, that I have seen that they have grouped differently, like the SMILE group and AMG group. My question is, have you tried that it is with AMG? Because your thing is much thinner, 100 micron, 140 micron. Perforation is say 500 micron, though it is small, maybe shelving is there. But if you top up with AMG, because there are several studies, only AMG can also correct the thing after a long time. There are very beautiful papers are there. So this is on top of it. If you give AMG, so it will be more strengthened. This is my suggestion actually. You can think and you can have, because you are doing it regularly. So in fact, the COVID has taught us many things. A lot of innovative thing. So even we are using like DISEC anterior cap. That is again more thickness, like 350.
Correct.
So DISEC anterior cap, DMEC, we can get the full thickness, lamellar, tectonic, perforation, whatever, up to 9.5 we could save for temporary purpose. Then you do the final procedure. So a lot of innovation has done, nice presentation, but preserving it and again use it for future is another option if you have facility of -80.
Correct. We can do that. I mean, amniotic membrane. What I find is that patients where we've used the smile lenticles have healed very well on their own in an excellent way. Amniotic membrane will, of course, add to it. There are only a couple of studies where they have used smile lenticule with amniotic membrane. The results are no different from studies where they used smile lenticule alone. There was one study in what I presented where they compared amniotic membrane graft to seal versus smile lenticule. There were two groups. They didn't put amniotic membrane on top. They used two groups. So their results were almost similar actually, not too different. The smile lenticule group was only slightly better. In fact, that's the only study which reported that there were some cases of perforation. Flat AC following that. Otherwise, all the studies have reported a very good outcome.
Okay. So can we add glycerin preserved corneas also in this?
Yes. So in COVID era, we used everything actually. So whatever in our hand.
Purpose is not optical.
Purpose is not optical. So initially, so anything in your hand spareable or you are throwing otherwise in the dustbin, so that is to be used.
So what we have realized is if you have a thick lenticule, don't throw it. Just save it.
Thick lenticule.
You never know where it might save you.
Required, yes.
Keep it for your emergency ORs. Keep it for perforating injuries which are stellate or they have tissue loss. You can use it in so many ways. It should be available 24 hours. Actually.
Also, right. Absolutely. Okay. Third. Shweta.
Yes. Thank you so much. I would now like to invite Dr. Shweta Agrawal. She'll be speaking about how the solution to some situations lies within and the use of tenonplasty and tenon's patch graft for corneal perforations.
A very good evening. This is really an interesting session where probably we are trying to seal the cornea with everything possible and just giving you many options. There is no best option, but it's, the best option for your patient at that very time with whatever we have. So the solution lies within Tenon's patch graft, when and how. I'm Shweta from Shankar Nethralaya. So for an ideal substitute for a corneal perforation has to provide a good tectonic stability, should be easily available and should be affordable. Well, the concerns that are present, that are with the present options available, cyanoacrylate glue is extremely good with perforations which are less than 2 millimeters. A multi-layered amniotic membrane, we are not very sure about the tectonic stability that can provide. It can be used for a persistent epithelial defect with an early melt. And corneal and scleral patch graft, you always have a concern with as far as the tissue availability is concerned.
He has to sign the attendance.
Now, why tenons? Tenon's capsule basically has the anterior and the posterior aspect of it. The posterior tenons is just a condensation of collagenous fibers. However, your anterior tenons capsule is made up of collagen, elastic, and smooth muscle fibers. And the rationale behind its use is basically it produces autologous fibroblast and connective tissue, which provides a structural support, reduces inflammation, and accelerates wound healing. Where the use of tenons was first proposed by Dr. Vajpayee et al. And from then on, people have been using tenons in multiple indications. When to do? Most commonly, it is preferred that you do it in patients with autoimmune disorders. In infectious keratitis, the results have not been very encouraging. The size of the lesion that you can manage with a tenons patch graft is somewhere between 3 to 6 millimeters. Well, how do you do it? You can anchor it using a fibrin glue. You can use stay sutures, a 10-0 or a 9-0 nylon interrupted sutures, or an overlay suture. And in larger grafts, you can use the sutures and use cyanoacrylate glue at the edges. Just a small video to show how we do it. So you just mark the edge a little beyond the area of involvement, trephine it with, so that you have a regular trephine, 0.5 millimeters larger, go a full thickness into the area of the harvesting that you are chosen from, cauterize the underlying bed. This fibrin glue can be anchored using, the tenons can be anchored using a fibrin glue and then with interrupted 10-0 nylon sutures. The donor site is approximated using a cautery. And since this was a patient of Stevens-Johnson syndrome and we were worried about epithelialization in this eye, we have just applied a thin layer of cyanoacrylate glue over the surface and placed a base seal. A small, simple procedure, but at hand and of use, especially in eyes like this. Thank you.
Thank you, Dr. Shweta. I think that was really cleared all the concepts. Any comments from the panel?
Yeah, tenons patch graft is a very useful technique. It's autologous and certainly a technique which everybody should be familiar with. It's very useful.
Yeah, I think we should be all grateful to the AIMS group for bringing it forth. It's a beautiful technique. Beautiful technique and something, sundar, sasta, tikau, always available.
Now, only my one question that on top of it, you put cyanoacrylate glue.
So in this patient, because
this patient, not in all patients.
No, so this patient was a case of Stevens-Johnson syndrome. And when this surgery was done by one of my fellows and he was not very comfortable, he was not very...
sure about the leak part.
No, not the leak, sir, the conjunctival epithelium. So when we stained the tenons graft, we had in fact harvested it with the conjunctival autograft, but the handling of the tissue was not as good as it should have been. So it had an epithelial defect. And because this was a patient of Stevens-Johnson syndrome, we didn't want to take any risk. So which is why we applied a thin layer of cyanoacrylate glue over it.
Madam, I have a question. How thick do you want the tenons patch to be?
So
sometimes, you're harvesting, you have a doubt how thick you want it to be. Your comments on that?
So it depends again on your host bed. And most of the cases, what happens is you have a central small area of perforation and your periphery is still okay. And if you don't put adequately, that area is going to leak. So your cystoid cicatrix or your desmatocene. So what we prefer, like we did in this patient, is you take a small trephine of 3 or 4 millimeters, you mark a ledge, and like you do an LK, so in the peripheral part of that area, you do a lamellar dissection. So you have a good host bed, and then you take a full thickness bunch of it so that the central part where there is a perforation, you have an adequate tissue, and the peripheral part you have already made a lamellar bed. So there is no bulge or the surface is flushed. So
and continue to that question, that which site is you get the thickest tenon, which quadrant or which clockward? From practical experience in young, we know that old patient you do not have any prediction, but young group.
Usually the fornices, I think, are good enough.
Now, which side of the fornix? Temporal, nasal? Now, I'm just asking. Long time I have not done it.
I get your point. I get your point, Dr. Basak, and this is actually a very important question. So usually the temporal inferior half would be a good place to harvest your conjunctival, your tenons graft.
That is the bulbar part of the
fornicial bulbar.
Another comment is, I have learned one thing. I mean, relearned rather, that everyone showed your videos that sharp edge is different techniques are there. You have taken a punch, refine, they have taken, someone is using the blade, but that is one of the important step. Not just that is a perforation, you put either a patch or tenon or whatever, but you have to give a clear margin with a sharp edge. That is one of the important factor, because the bed, there are some residual corneal tissue in that area that will help to anchor whatever you are putting over it. Otherwise, there will be leak.
Yeah, so absolutely. If you don't have a good graft host junction approximation,
This is
even
for
the
you.
epithelial healing is going to be an issue. It's just like doing any LK or a PK suturing. You know, your epithelium is not going to jump. So it has to be very smooth. So, yeah, Dr.
Because-
Basak, the
because
point
some-
well taken.
Madam,
Because
my
the juniors are there. Yes, one question.
Infectious keratitis, if there is a perforation, if this works in such cases.
So, sir, we are honestly not very happy using a tenons in case of infectious keratitis, and whatever literature I did go through while making this talk as well, they have not had encouraging results with tenons. Multiple reasons. One is the entire area is very necrotic. So, you know, anchoring this tenons also is going to be difficult. Underlying the tenons, you won't be able to see what is happening to the tissue. So in infectious keratitis, my bet would still be, if it is a smaller perforation, I would still go for a cyanoacrylate glue with a BCL. And if it is a larger perforation, a patch graft using any of the other tissues like cornea or sclera. Anything else that?
Yeah,
No,
this-
absolutely, you are absolutely
the technique of suturing, like many people have described, one is that you actually pass the sutures like you showed, and another is that you kind of like just anchor it over some kind of
Overlay,
mattress kind of
overlay.
sutures, like overlay sutures. Now, in these kind of situations, like especially infective keratitis or something, I mean, results in my hands are very, very good with just those kind of anchoring, compressive kind of mattress kind of sutures,
Overlay
which
suture.
is overlay sutures. So, what is your take on that? What kind of sutures? Even the case that you showed, I think, had you put overlay sutures, I think it would have done
No,
maybe
it is
reasonably all right.
actually
Or no, it
case to
wouldn't have.
my opinion, it is case to case basis. What Amit is, I fully agree. Sometimes initially, my initial years, I used to give, because I cannot pass the suture. There is cheese wiring, so limbus is clear. So take a look, and I used to take 9-0 suture. Mind that, not 10-0. 9-0, you have a very good tight. So you
I
give
think that's
like
a nice step using a 9-0 suture.
Correct.
So
You give more
like
strength,
a
tension.
mesh, you are creating a mesh over tenon.
Correct.
And in full
So,
thickness
and
perforation,
later
it
on
does
you
very
can
well.
remove very
extremely well.
early.
It
Very.
heals so well, because to pass sutures through tenons is very, very tedious.
Tenon is tedious, and also if it is necrotic, like viral keratitis. So you go beyond, then you get actual good stroma, then you can pass. Before that, there will be cheese wiring, and your surgery will be more messy.
Correct.
Correct.
So overlay suture in those cases
Overlay
is
with the 10-9-0.
9-0, you get good strength actually. You, like tightening of the suture, it is very good. Chalo,
Thank you
very
so
good
much.
discussion, Shweta.
Thank you so much. So we go ahead with the next presentation, Professor Chintan Malhotra, Customization in a Crisis, Shaped Graphs for PUK-Associated Perforation. And I'd like to invite co-instructors, Professor Arun Jain and Dr. Ashok Sharma to please join on the dais.
This is not an instruction course. This is actually a symposium kind of thing. Because the discussion is there now.
Well, thank you, ma'am. Can I have my slides up, please?
Symposium.
Symposium kind of.
So as we're having this discussion on corneal perforations, we see that we get many cases in different shapes and sizes. And what I will be speaking about is customization in a crisis, how we can shape our grafts to better fit the perforations that we have, perforations or thinning that we have, specifically PUK. So just a quick recap of PUK. We know that 50% of the peripheral ulcerative keratitis cases are associated with collagen vascular diseases, of which rheumatoid arthritis is by far the most common, but we also see fairly, especially in referral institutes. Yeah, okay. The granulomatosis with polyangiitis, previously known as vaginous granulomatosis. Infections, whether bacterial, viral, or fungal, are another important cause of PUK. And then once we've excluded all causes, Murren's ulcer remains an important entity which we often see. Now, corneal perforations complicate a large percentage of these patients, and those who don't present with perforations may have impending perforation, and that's also the situation where we want to treat these patients. And why I mention these causes is that it is important to treat the etiology along with doing the surgical treatment. So just an example of cases, the pictures that you see on the left of your screen, this was a lady very, very sick who presented. She wasn't diagnosed earlier. We sent her systemic investigations and she had an undiagnosed rheumatoid arthritis, presenting with bilateral melt, peripheral melt, a desmetocele in one eye and a frank perforation in the other eye. So this is what we would see as a classic, very acute presentation when the patient also has other comorbidities which need to be taken care of. The picture on the right side of the screen shows a 28-year-old lady who for 2 years was diagnosed as a rhino-orbital disease, being treated with ATT and antifungals, but for some reason she had not undergone systemic investigations. This was a patient referred to us again from outside. And when she came to us, we got the investigations done. It was again ANCA positive and a diagnosis of GPA was made. So now what are the options that we have in these cases? We could use circular grafts, that is full thickness penetrating grafts, which could be large grafts, which carry with them the risk of increased vascularization and graft rejection. Or we could have smaller eccentric grafts, which carry the risk of the graft coming into the visual axis along with other problems. So in these situations, shaped peripheral grafts are the preferable option. They may be lamellar, which again is preferable, or they may be full thickness depending on if it's already perforated. And they can be biconvex or crescentic depending on the situation, biconvex being preferred for smaller areas and the crescentic grafts being used for large areas of the limbus being involved. The advantage of these crescentic grafts is that they have a minimalistic approach and they avoid sacrifice of the uninvolved cornea, which you see with the full thickness grafts. Now, there are multiple techniques which have been described for handling these grafts, the copy and fix, prick and print, crescentic tilk, and multiple others. Basically, these use some common sets of principles. Either they use the tracing technique that they trace the underlying pathology, or they use the freehand technique. And then to dissect the donor, again, you could go freehand, or more preferably use trephines or use dissection on an artificial anterior chamber, which again are preferable. I'll just show a couple of videos. The copy and fix where we trace is my preferred choice, just makes it easier. So this is the same patient, the young lady which I showed the video of. So after you've managed the systemic condition, a conjunctival peritomy can be done, it has to be done with minimal cautery as much as is required. The lamellar bed needs to be handled carefully, and we try to make the bed as smooth as possible and try to create a peripheral groove wherever possible. Now, this was the donor tissue which was taken on an artificial anterior chamber, and a lamellar dissection is being done. This tissue is placed on the overlying defect, and then we are seeing what was the underlying pathology. And this is your copy part. You're copying the lesion. And then a trephine of an appropriate size can be taken, and we get a nice crescentic graft, which can then be fixed onto your bed. Now, in most of these cases, we would use sutures. It's okay to either oversize the graft a little, or you can have it the same size. And then one would use multiple sutures to try to fix this graft. Now, in this situation, somehow I felt that suturing the inner edge of the graft, the host tissue, there would be a lot of cheese wiring. And so at that point, we left it unsutured because we had used fibrin glue, hoping that it would heal. And so you get a reasonably good fit, and we covered it with amniotic membrane. But later on, as the graft retracted a little, we saw that the edema was not healing. And so then at the second sitting, when there wasn't cheese wiring, we put in some sutures and had a good outcome. But of course, you need to be patient with these patients. This took around 2 months to arrive at, and so you don't need to worry. And if you have access to an intraop OCT, you can use that, but it's not something which is mandatory. Now, the fixing that I showed, that was a lamellar fixing. It can be done either also full thickness or a tuck-in also. So just another video, this is not a case of PUK, but just to demonstrate the principle of how a full thickness can be done. This was a lady who had a traumatic cyst with a wooden injury, just to show the same principle. The cyst was excised, and mind you, this was the better seeing eye of the patient. So again, we copy what was the large scleral defect, and here a freehand dissection has been done, not a lamellar dissection, a freehand full thickness dissection has been done. And then this was sutured onto the scleral defect. I prefer to use cornea here, and there are publications which show that sometimes corneal tissue is better than scleral tissue for the defect, but that's another discussion. So just to show that full thickness grafts can be taken, this can be covered with AMT, and then this was the patient at day 14. This is her only seeing eye, and the defect gets covered by the upper lid, and the patient is like reasonably happy. As Professor Radhika mentioned, sometimes we do get larger grafts than we want to see, but it's okay to go ahead with them because we don't want to do a full large limbal graft at that point. And then there's this other technique, which is the stencil-based prick and print, where you can just copy onto a plastic sheet the defect, which is whatever is your pathology, and then trace that onto the donor graft. The advantage of this technique is that this can be used for scleral patch grafts also, because here you don't require transparency, which you require for the copy and fix technique using the cornea. So to conclude, the surgical goals are restoration of surgical integrity. Lamellar surgery is preferable to full thickness grafts, and our aims are to minimize limbal stem cell damage, avoid unnecessary removal of healthy central cornea, and reduction of ectasia and induced astigmatism where possible. And the important surgical caveat, as Professor Radhika also mentioned, it's important to recognize that surgery may not be the best solution in every patient. Co-manage the patient with your other colleagues. And this is a patient who was managed just on immune suppression and required no treatment. So that's important. Thank you very much.
Thank you very much, Dr. Chintan. Nicely covered, and very nice practical teaching about how to match the graphs. And I think anything anybody else wants to add?
Just beautiful cases, Dr. Chintan. Just beautiful surgery and beautiful cases.
Thank you so much, because it's the shaping and the sizing which is often a problem, which you sometimes
it's always the edge which becomes a problem in such grafts, especially when you have all these different sizes and shapes coming in. It's the edge which makes the lot of difference.
And you sometimes trim it and it becomes too short, and that's the problem.
Well, one thing I would say that the glue augmentation is very useful, because if you put a thin layer of glue at the bed, it allows it to integrate, and it acts as a substrate where the neighboring macrophages and the fibroblasts and the keratocytes can, so you put, and then you don't have to put that many sutures. So that's also useful.
Excellent presentation, Dr. Chintan. And
Mine very good. I am very comfortable with it.
Yeah,
and especially the sepet graft, the peripheral crescentic graft, it works very well. But for the larger defect, it is definitely, because since we are using a plastic sheet which is not covering the contour of cornea very well, so that is the problem for bigger graft. For a smaller graft, it is
for smaller grafts it would work very well. Yes,
definitely, because the purpose of the technique is mostly tectonic, so we never bother about the endothelial cellulose, which is you do in copy-paste technique. So many times for tectonic purpose, we use that anterior button from the dissect tissues also, because the purpose is only to restore the integrity of the cornea.
Absolutely. And I think sometimes the peripheral crescent, when you're using even you're doing the penetrating keratoplasty or something, you have those peripheral crescent left, and you can get those small the small circular grafts on that. Those also should
my experience is that rather than if it is possible, rather than manual cutting, if you can use trephines to customize the shape and size of the graft, that is better. That is much better, and you don't excise the tissue from the ulcerating area, and you determine the geometry, all the dimensions, and try to get the similar tissue and try to fit it. It works very well. And wherever, even if you have a perforation, maybe 3 millimeter, I have treated even up to 4 millimeter perforation, you try to put the lamellar graft and do little bit of PI at that area of perforation, push the iris inside, put some pilocarpine, and it gives beautiful visual outcome also, in addition to tectonic. technique. And one observation that the inner side, I never want to leave it loose, because in all these conditions, it's the melting of the tissue. So if you are leaving that unsutured, the chances of the melt again developing is much more. And I think that's very good point Dr. Radhika told, that we should put some fibrin glue which will seal it, and that will promote the healing.
Just one comment.
Cost. And you know that counterpart in India is not working recently, and batch to batch variation is so much. You do not like that really seal. One batch might be good, but next batch you are not sure that it will act or not. But other one is good, but the cost is now 12,000. Too much. So and unless you have, these are emergency patient. It is not like they plan pterygium surgery, 10 pterygium surgery.
And often a lot of these patients will be the ones who can't actually afford.
Cannot afford. That
and so we are trying. So you have other people in the OT. Sometimes the retina people are
retina people. So you borrow for them then.
Yes,
so
yeah.
so this happens everywhere in our place also.
Yeah.
So
just one. Just one comment. You have to have a King's clamp handy with us, because most of the time we have a corneal scleral button. So if we really want a very good cuts with Trefine, you have to have a King's clamp handy with you. Otherwise, you won't get a very clean cut. There are other ways to doing it. Some people wrap it on a gauze and then do it, but then you don't get a equal pressure. So it's maybe mandatory to have a, or you have to fix the corneal scleral button into an artificial chamber.
Artificial anterior which are easily available, the disposable ones, and they're not expensive.
But all, as we said, all these are emergency procedures people are doing in periphery. They may not have artificial chamber, but King's clamp is a very, very economical alternative to have this thing done in a meticulous way.
Just to add to that, other than this surgical excellence, we have to remember this is a temporary thing. We are buying time, and after doing this, the original systemic condition has to be addressed aggressively.
That is, I think, the most
otherwise
important.
Definitely it's going to recur. So that's what we have to keep in mind.
That has to be managed primarily. That's it. Thank you.
Thank you, Dr. Chintan. Now we have a presentation by Professor Arun Jain. Look no further, conjunctival pedicle graft to the rescue in peripheral perforations.
So thank you all the people on the dais for having me part of this program. So we were talking about the cost factor. So here is a procedure which has minimal cost involved. The cost it involves is only a suture, 10 nylon suture. Rest of things are, you may not have everything available in emergency theater like a glue or a donor tissue. So what to do when you are faced with this perforation in an emergency situation where nothing is available except suture. So I will be emphasizing the conjunctival pedicle graft in the management of corneal perforation, especially the limbal sparing, because we don't want to leave behind a limbal stem cell deficiency. And the indications already has been highlighted by the previous speaker. These are the common causes of corneal thinning and perforations. The commoner ones are after the bacterial ulceration or dry eyes, neurotrophic keratitis, or collagen vascular disorder. And all of us are familiar with the medical management of the disease. Once the medical management fails, the persistent corneal ulceration doesn't respond to our conservative therapy. So various alternatives which has already been highlighted in the form of either fibrin or cyanoacrylate glue or amniotic membrane or patch graft, lamellar or PK, all are available to us, but I will again be confining myself to the limbal sparing conjunctival graft. The reference of these conjunctival graft goes way back to more than a century, when Beers described conjunctival flaps in ophthalmic surgery. And then again the reference was made by Green J in 1927, and first time in 1958 Gunderson described the classical Gunderson flap based on the reported in Archives of Ophthalmology. And 11 years later, he published around 31 cases of corneal thinning or perforation because of the various reasons by doing a Gunderson flap. And these were the indications for doing Gunderson flap in those cases. And with the progress of microsurgical technique aided by very good microscopes and fine surgical tools, I think selective penetrated conjunctival flaps cured in place by fine suture tailored to cover area of the diseased cornea, chronic ulceration with or without corneal perforation is a good technique and may be performed in an outpatient setting, and post-operative recovery is quite rapid. And this paper in 2003 in Archives of Ophthalmology, again by Khodadost et al., they described management of these corneal perforations by conjunctival flap, but they didn't do limbal sparing pedicle conjunctival flaps. In this, half of the 11 cases had a perforation in these cases. So the objective of surgical management, as we all know, is preservation of corneal and globe integrity as far as possible, and minimizing lesions incompatible with functional vision, and replacement of lost corneal tissue, and increasing the blood supply to the healing cornea. So, I think this is, and preventing any localized limbal stem cell deficiency which may be induced by dissection of conjunctival pedicle flap should also be avoided. So we did this limbal sparing conjunctival pedicle flap in 21 patients with corneal ulceration with or without perforation. 2 cases had corneal foreign body induced keratitis with perforation. 3 cases had post-chemical burn. 1 case of post-keratoplasty. 2 had corneal trauma. 5 had corneal non-infectious ulcerative keratitis. 2 had neurotrophic. So these are the indications in our cases of 21 cases. So this is one case of post-trauma which was badly sutured outside, and you can see the necrotic tissue. The chamber was flat and leaking. The person outside had already done a CI. So after removing the sutures, which were very bad, 80 silk, and removing the necrotic tissue, we fashioned a pedicle flap. You can see we have spared the limbus, and injecting the saline or xylocaine with the adrenaline, make a very thin flap, as thin as possible. But if the corneal thinning is too much, then you can include tenon also along with this, and then suture it. So this part is attached. You make a oblique this thing so that there is no folding of the conjunctiva at that point. So this is what post-op day 1, and over a period of time, patient healed like this. After 1 year, I did a cataract surgery also with very good 6/9 result in this case. There's another case who had a peripheral corneal ulcer which was not amenable to medical treatment, and we did again a pedicle flap with a good result, 20/40 vision unaided. And this was another case who had corneal infiltration with the foreign body. Once the foreign body was removed, it started leaking. So because it was infected and there was a speck of a satellite lesion also, we thought of doing a patch graft, but then we thought we will have to include this area also. Then I went ahead to do though this was small perforation, so I went ahead with the pedicle conjunctival graft. So this is the healing, though there is a little incarceration of the iris at that place. And this is a post-burn. We put this was a grade 4 chemical burn. We put a glued on contact lens. Once the lens fell off, there was a persistent epithelial defect. So here we did a very thick conjunctiva and tenon, included a racket graft, and the persistent epithelial defect healed, and later on we referred the patient for keratoprosthesis. This is a very young child, 7-year-old male, had a corneal fallen body with again infiltrate. We tried to glue it 3 times, but there's a child, every time he'll rub and come back again with the perforation. So again we did a pedicle conjunctival graft which healed over a period of time, again sparing the pupillary axis. and a good result. So we, out of 21 patients, we had 5 had a corneal perforation. All of the patient had a stable pedicle graft. In one patient, slight graft retraction occurred on 5th day, which was resutured, and corneal ulcer healed in all cases. Globe integrity was preserved in all patients. None of the patients developed glaucoma, and none of the patients required patch graft or therapeutic penetrating keratoplasty. So to conclude, conjunctival pedicle graft is an appropriate procedure to manage corneal perforation and impending corneal perforation where donor material is not available and transplantation of such tissue is not suitable. The technique is performed easily, can aid in the healing of the area of thinning that threaten perforation by providing a vascular pedicle, and limbal sparing flap in presence of healthy limbus in addition helps prevent conjunctivalization of the cornea and therefore gives good anatomical as well as visual outcome. Thank you very much.
Thank you very much. Can I just ask one question, that when you make the pedicle, the rest of that area, you suture it or you just let it to heal on its own? The disconnected area.
Yes, or you can apply 1 or 2 suture to cover that area.
Just to cover it.
So that healing happens much faster and inflammation also is less. But then again, if you have a glue, you can pinch it also, but then again the cost factor will come.
Yeah, that is true. Thank you.
I think for youngsters, those who wish to perform this procedure, Professor Ranjan has pointed out very rightly that you have to spare the limbus. And you must have seen he has marked sparing the limbus so that the limbus stem cells are not disrupted. I have 2 patients for whom conjunctival grafts were done for ulcers from outside, and they were referred to me. One is that if there is a frank infection which is not being controlled, then this procedure should be I would say avoided, because then the infection is not healed with this one. But in both these cases, the limbus was not spared. So once we controlled the infection with the antifungal treatment, because both were fungal, so we reposited the flap so that the limbal to the original position, so that the limbus stem cells are not disturbed.
I would like to invite Dr. Vanati to please come on the stage. Yes. I'll go that side.
Thank you. I think we are having a very interesting discussion. And next, I'd like to invite Dr. Ashok Sharma to give his talk on cyanoacrylate glue. We all know that cyanoacrylate glue is something which is one of the most common procedures which is done for corneal perforations. When done well, it's a very, very effective technique, but if not done well, it has its own set of complications. So we'll just hear what Dr. Sharma has to say.
Good evening. At the outset, I would like to thank the organizers for giving me opportunity. In the era of cellular regeneration, we are having many options for treating corneal perforations. We have fibrin glue, we can use amniotic membrane, and we can have some of the latest techniques which are still under investigation. You can have mesenchymal stem cells also. You can use them with fibrin glue. But cyanoacrylate tissue adhesive remains the time-tested modality. And the most important thing is that it's cost-effective and it's easily available. It can be stored in any cornea clinic. When I did my residency, at that time this glue was not available, and we used to get it from Germany, and you will be surprised that one vial used to cost 15,000, and some of my patients had imported at that time. So corneal perforations, whatever name we give to it, whether fistula or whatever, the treatment remains the same, except for the large corneal perforations where we will need surgical treatment. Again, for different etiologies, when the perforation occurs, it is because of the continued collagenolytic activity. we need to understand that once the perforation has occurred, we need to have a different kind of management strategy. And in most of the times, peripheral areas, the corneal perforations are missed. And even if from tertiary care centers, these patients with perforations are advised these modalities, sometimes they are denied that there's no need, we can treat with medical treatment alone. These are some of the clues for the corneal perforations, and the most certain clue is that your anterior chamber will be shallow and the iris will be presenting at the site of perforation. But these other subtle signs should also be looked for the presence of corneal perforation. This test remains the most important test, and we can perform it in two ways. If we have concentrated fluorescein strip, then you will get this kind of green lake against dark background. If you are using diluted one, then there will be clearing of the fluorescein. If you are not getting it, if you are strongly suspecting, you can put little bit of pressure. If your patient is having dry eye, then put lot of solution also, like which will yield positive result. Once there is a corneal perforation, we have to understand that medical treatment alone will not be sufficient. We need to have additional options to treat these patients. That may be in form of tissue adhesives, therapeutic, or conjunctival grafts. These are some of the tissue adhesives which are available to us, and there are various methods to apply these tissue adhesives. You can use like toothpicks, you can use disc applicator, you can have special applicators for that. But the most commonly performed and which gives best results in our hand is that you use a syringe. If you are happy with the insulin syringe, you can use that, or you can use 2 cc syringe. But take tissue adhesive to the minimum quantity possible. Don't use a larger amount. This small video will just demonstrate this technique. Can you help me? I think there is some problem with the...
Can we request the audiovisual team to please look at it?
Is the video there separately?
We have like a few important points once we apply this tissue adhesive. One is that we need to dry the area where we want to apply the tissue adhesive. The second thing is that you need to de-epithelize that surrounding epithelium. You have to remove the surrounding epithelium. Now there are two methods to remove the surrounding epithelium. You can use like 26 gauge needle if you are comfortable with it, or you can use crescent knife if there is not much of the ulcerating area around.
Take the next speaker in the interest of time. We will sort it out. The next one can take this one. We have 3 more.
No other option except to do a therapeutic graft, and that itself is sometimes one of the most challenging surgeries to be done. So therapeutic grafts are more difficult than optical grafts, actually speaking, if they need to be done well.
Good evening, everyone. At the outset, I would like to thank Vanati ma'am for giving me this opportunity. It's really an honor for me to be a speaker in front of you. So this is my presentation on the last bastion of the infective perforation, that is therapeutic penetrating keratoplasty. So these are the various causes for the infection. I'm not going into the detail. I just would like to highlight my individual techniques. So the purpose of management is obviously the tectonic as well as the therapeutic. And these are the management options the previous speaker already discussed. So what should we use and when to use, this is depends on the size of the perforation as well as activity of infection and availability of the donor tissue. So role of patch or therapeutic graft comes if it is very large or active infection which will achieve tectonic as well as therapeutic purpose simultaneously without any disfigurement to the surface. So here I would like to present a video of a case where there is no other options presented before works. The only option left is the therapeutic patch graft. So it was a case of anterior staphyloma with normal B scan. So there is a good visual potential. So we decided to do therapeutic or more of the tectonic kind of graft here. So this is the video. First, I would like to do the peritomy. 360-degree peritomy was done, and after that, I never use the trephine in such cases because it is not fit usually. So I deflated it and separated the iris which is attached to the staphyloma very carefully. Should not, and I protect it with the help of forceps, blunt forceps. Now I excise this extra ledge of the tissue, and then I found that the iris is stuck inferiorly to the peripheral cornea. So I release it and release all the membranes from over it. I cut that atrophic iris tissue and then tried to did pupilloplasty here. So I managed to do a pupilloplasty here. This gives me benefit of less chance of the glaucoma, better photophobia tolerability, as well as the good shape of the pupil, and better IOL stability later on. So, and then I found while suturing, I found that there is a crescentic defect is there. So I just take an idea of the dimension and then I cut it from the peripheral rim with the help of trephine and fit it, incorporate it along with the sutures. So it will never compromise the shape of the tissue. So one can do this with this technique, and then we could achieve a good outcome, and we decided to do cataract later. This is again an individualized technique where we do a patch graft as routine. Here everything is similar, the technique of suturing is different. So I remove this necrotic material from there and then use trephine to outline the melted out tissue and excise with the curved 1/2 scissor, and then I took this peripheral rim for the patch graft harvesting. I marked the graft because these are the smaller graft and may disoriented while suturing. So I put this graft, and the suturing technique is different here. I first take a suture in the host and then from the graft and then again with the host. So instead of putting two sutures opposite to each other, I use a single suture from the host, then graft to again then host. So this is actually sandwiching that graft in between the edges of the defect. So and at the same time we need less number of the sutures here. You can see that usually we use at least 8 sutures, but here we can use only 4 sutures. So these are the 4 sutures are good enough to achieve a good tectonic stability and good sealing effect. So this technique we give the name the suture across technique. So after putting these 4 sutures across the graft, we bury all the sutures, and then we did synegalysis and then wash the anterior chamber. And we get good tight, and you can see how stable is the wound and what a sealing of the defect. There is no leaking at all. So this is my preferred technique. Then again, madam already talked about the stenciling. This is our technique, and it works very well with my hand. I first excised the peritomy and then did cauterization, then mark the outline of the defect and put a transparent sheet over it. Now we only scratch along with the markings, not actually pricking the markings. We just make scratches. It will be visible, and then apply it on the this mounted cornea, and do apply this ink along with it, and you will get a sometimes smudging of dye is there, but you will get an idea of that. So first we do a partial thickness cut, and then we do a full thickness cut. Otherwise it become very flaccid. And then we resected out this diseased tissue, the necrotic cornea all around as per the markings, and then we fit the tissue and secured it with 10 nylon interrupted sutures. And this is the post-op picture. And this is again a very individualized technique. We recently used this. There is a fistula with the continuous oozing through it. And though there is no visual potential, but we decided to seal it because there is risk of infection and prolonged hypotony. So here what we did, as you can see, the oozing is there. So we just tried to get the thickness of the tissue, and we marked a rectangular shape, and then we did a lamellar dissection over here. So this is lamellar, anterior lamella we prepared all over the markings with the help of crescent knife. This is otherwise end stage eye. So we just rotate it just like what we do. Okay, so just we rotate that graft, just like what we do to seal our container of pepper and salt pepper. We just rotate it and it seals. So we just did. This is better in end stage eye like Steven Johnson and other eyes. So this can work. I very recently did this technique and secured with this partially overlay suture. And it secured well. I demonstrated there is no oozing, no leaking. As you can see, there is no oozing at all. It's secured very well. So this works very well in end stage eyes like Steven Johnson and very diseased ocular surface, because the same autologous tissue is there.
Very good.
So
Absolutely. So you don't have to place an amniotic also, which is again extraneous tissue. Yes.
Visual potential, but we need to seal that perforation. So this can be done.
Yeah.
So this is again a therapeutic. We decided to do. This is actually a desmoid seal, as you can see. Okay, finish.
Yeah.
Okay, so my take-home message is there are so many options for management of perforations. We should consider the size, infection activity, and availability of donor tissue for choosing options. The page grafts best for the large perforations and active infections solve the therapeutic and tectonic purpose simultaneously. Thank you.
Excellent videos. Thank you so much. Just one question for everybody present here. What is the exact plastic sheet that you use for your, because like you mentioned, the contour of that
we
would be
use the
important.
wrapper of this 10 nylon sutures. That is transparent on one side, and other side it is opaque.
Okay,
So
let
we
me
use
project
that
yours.
sheet
Let me
only.
project
We
yours.
actually need very small sheet,
Huh?
not a big one. So we can use that wrapper
Of the 10
wrapper of the 10 nylon suture.
That is already sterilized.
Yeah, already sterilized, sir.
Good.
Yes.
Very good.
Thank you, sir.
Great videos. We have all got good ideas now to go back to.
The beauty of the, should I start?
Yes, please.
The beauty of the synovial tissue adhesive is that it can be used even in presence of infections. Once the infection is controlled, it can be used for even perforated fungal corneal ulcers. If you don't want to use bandage contact lens in infected corneal ulcers, you can use a drape sheet and put a glue and then use that. The problem is when you have a larger perforations, and these perforations you cannot put glue because directly they will go inside. So I use a barrier, and I have tried different barriers. I have tried cornea also, but the cornea swells. So I started using partial thickness scleral patch, and that is fitted into the corneal perforation, and if needed, 1 or 2 sutures. Now this patient has healed very well, and these sutures we have removed. Now you can see that the anatomical result is very good, and also the visual outcome is very good with this technique. This is just a diagrammatic representation. This is another technique that if you have a good thickness surrounding the corneal perforation, you can make a lamellar pocket around the corneal perforation and then use the scleral patch, put the scleral patch in the corneal perforation and apply glue over the perforation. You can see this is the diagrammatic presentation. This is a little bit of video, but I don't think we can avoid that. This is good technique in my hands, and only problem is that sometimes the patient does complain of cosmetic problem, but then if it is central giving cosmetic problem, you have to do penetrating graft. This also we could publish in IGO. This is most interesting case still now with me. This patient was operated for pterygium surgery elsewhere and was referred to us for management. You can see there is a large corneal melt, large perforation, large scalar and limbal melt. So I was in a problem that what to do for him. Ultimately, I thought for this patient also we will put a scleral patch, but in this case we will put a scleral patch right behind the perforation, slightly larger than the perforation, and then apply glue. Surrounding corneal melt and scleral melt was treated with the amniotic membrane. And this is the diagrammatic presentation, and this is the post-op pictures. It healed very well. And finally, we could present this, publish this patient paper in JOVR. We have extensive experience in glue, and we have published several articles, and one of our articles has crossed 200 citations, and this is the most satisfying article in which we have summarized all our experience and also other modalities of using the glue in perforations, and I am also grateful to all the co-authors for this. I would just like to show this slide that if you see this picture, these camels you are seeing, they are not camels. The camels are the gray shadows, because this is the aerial picture. So this is what happens with corneal perforation. Unless you look for it and you do a Seidel test, you are going to miss it, just like we are missing camels here. Thank you very much for patient hearing.
Thank you so much, sir. And I think we'll take questions on this a little later. In the interest of time, we'll move on to the next talk, which is by Professor Vanati, and she'll be speaking about the role of amniotic membrane in managing corneal perforations.
Thank you, Chintan. So in the next 6 minutes, I'll run you through a number of case scenarios. It's more like a vast session here on the uses of amniotic membrane as an adjunct to corneal thinning and perforations. No financial interest here. So you can see this is a case of a persistent epithelial defect here, which is non-healing in this patient after an operated penetrating keratoplasty here, has had multiple interventions here with all the probable medical management, bandage contact lenses done, but not really helping in, and prolonged epithelial defect is also causing a central corneal thinning in the region of the epithelial defect where the Bayer's stroma is lying exposed here. So amniotic membrane comes in useful in this scenario here, and you could plan an amniotic membrane inlay with an onlay here. So a custom fashioned or a hand fashioned inlay of amniotic membrane is being done here, and you can put in your 10-0 monofilament nylon sutures, an inlay, a multi-layered inlay, could be 2-layered, 3-layered or 4-layered, depending upon the thinning of the cornea which you would want to add up and you want to cover up here, and that really helps in healing of the persistent epithelial defect, especially when it's gone on to a neurotrophic stage. Sometimes you might have to repeat it a couple of times, and this especially can happen in poor ocular surfaces, and when you're doing real bad therapeutic keratoplasties for severe corneal ulcerations here. Here you have yet another patient here. You could see that this was an operated keratoplasty with a recurrence of a herpetic infection in this graft here. All the medical managements failed, but the viral infection was controlled, but this geographical ulcer is no longer infective, but was a neurotrophic ulcer here. So this is another scenario here when the Bayer's stroma lying left open for a long, left exposed for a long period of time, again needed an overlay here. The thinning here is not so bad, so I've used a multiple amniotic membrane overlay here with no inlays in this particular patient. multiple layered inlays does keep the membrane on for a longer period of time and gives you adjunct, you can add on adjunct medical therapy and perhaps repeat it after a particular or a longer interval of time in such cases here. Here you have yet another patient of, this was an ocular patient of ocular GVHT who went in for corneal perforation with severe tectonical thinning, a very bad refractory surface which was not healing with any amount of medications. We had put him on platelet lysate drops. We had given immunoglobulin. But he got lost during the COVID period and came back necessitating a therapeutic keratoplasty. Two interventions, and this is a third intervention where then you could see the underlying thinning in this particular patient here. And again, amniotic membrane is what comes in help for you, and you have a custom fashioned multi-layered inlay covered by an onlay to save this particular eye here. And once you remove these necrotic tissue, once you remove the heaped up surrounding corneal epithelium, the surface inflammation does go down and really does help in managing the patient here. This is another 80-year-old gentleman who reported to us with, you could see the surrounding Murren's ulcer kind of a picture here. And here you have this peripheral ulcerative keratitis, which has been sitting on for a long period of time. But the thinning was not something which really warranted a lamellar graft on here. So we freshened up, removed the necrotic tissue over here, and used a custom-made semicircular semi-annular inlay and an overlay here with a little recession of the conjunctival tissue, surrounding conjunctival tissue. And this patient again went on to heal well after this particular therapy. Yet another patient where you could see there was an annular amniotic membrane oval inlay put in and covered by an overlay here. This is something which most of us would have seen several times here. This is a case of a Shields ulcer, a chronic Shields ulcer which was not healing and came to us with involving more than three-fourths of the corneal diameter here. So this was a glue-assisted multi-layered amniotic membrane with a bandage contact lens on, and this surface went on to heal with minimal scarring and restore visual acuity for this patient. Some other scenarios in which you would not want to burn your hands by doing therapeutic keratoplasties or lamellar interventions. These are neurotrophic keratopathy conditions, as in Mobius syndrome. This is a hereditary sensorineural autonomic neuropathy here, and these are conditions in which amniotic membranes work well for tectonic restoration of the ocular surface here. I think for lack of time, I'll run fast through this video, but here is an ocular surface reconstruction in a chemical injury, a chronic chemical injury sequelae with a total limbal stem cell deficiency and a preliminary release or symboliferon lysis in these patients. You have to follow an adequate technique so that you allow the existing conjunctival tissue to fall back into the phonesis and cover the residual defect on the central part of the ocular surface with amniotic membrane, multi-layered amniotic membranes, and suture them up. This helps to free the globe after removal of all the fibrotic tissue, and is best done as a sequential procedure before you want to consider doing autologous or allogenic slet for these chemical injury damaged eyes here. And yet another condition, this was a case of severe scleral thinning and scleral melt here. So I've done a scleral patch here, and here the conjunctival tissue is all fibrous, scarred, and also lost here. Amniotic membrane again is essential because you do not want to leave your scleral grafts unopposed in such scenarios, and amniotic membrane is really required to cover the growth when you do not have cover the sclera, when you do not have adequate conjunctival tissue enough to cover the large scleral grafts. Similar positions when you do filtering valve surgeries, when you put in your Ahmed glaucoma valves and you need to cover the scleral patch. Again, amniotic membrane works well in such scenarios here. I think I'll stop here and thank you for the patient hearing.
Thank you, ma'am. I think you've covered a host of the whole range of conditions in which the amniotic membrane can be
I think
used.
one other novel use of amniotic membrane, not only in the anterior segment now, I think the posterior segment surgeons also use amniotic membrane
For the
tufts to
macular
close
holes.
their macular hole surgeries. And that was something which fantastic, which I did learn when I was attending one other retina sessions here.
And in the interest of time, I will invite the next speaker now, Dr. Revati. And ma'am will be speaking about how best to repair traumatic corneal or corneoscleral tears. Meanwhile, any comments from the panel about the use of the dried amniotic membrane vis-a-vis the cryopreserved? Sir?
I have no experience on dry amniotic.
We had used a couple, but we were not very happy. It doesn't work.
Okay.
Yeah, thank you. For a change, now we are going to look at the corneal tear as such, not the perforations. And here, the aim is most of them may be medical legal also. The aim of the repair should be depends on the severity. If it is simple wound, we have to try to regain the corneal contour and minimize the scarring for the early visual rehabilitation. But in case of severe injuries, the aim is to reconstruct or regain the anterior segment as such, and then later we can do the further visual rehabilitative procedures. So the principle, these are semi-elective procedures. So injury can be within initial 24 to 48 hours, we can intervene anytime, provided that we protect the patient with oral antibiotic coverage or systemic antibiotic coverage, and do the proper investigation, assess the extent of damage, and then go for the plan the surgery and go for the repair. And also remember, it is essentially a microsurgery, and we have to achieve the functional results also. So the sutures we follow is we use 10-0 nylon, and what we should remember, a deeper curved needle, 160-degree needle, spatulated needle will be more useful for deeper sutures, and the spatulated longer curved needle will be used for the lamellar injuries. The suturing technique, as we know, we have to go full thickness almost and equidistant, so that the compression zone will be covered with overlap, and there should not be pouting either internally or outside the wound lip. The corneal tear suturing, first go for the identify the landmarks, and the prolapsed tissue usually will be covered with a fibrinous tissue. Separate it bluntly, with a blunt dissection, and remove it. And then if the tissue is viable, we can reposition it. We need not sacrifice it all the time. And the contour of the injury, like the tear, we have to assess, and we can follow the same contour, the landmarks, for proper and approximation. And we can, some of this wound, when it is central, we can use the same wound to wash off the cortex and other internal vitrectomy for other purpose also. So first fix the limbus, and then you can see in this injury there are curvatures. It's like an almost S-shaped or double S. Then use the same curvatures as the landmarks for proper approximation with full thickness sutures. And this approximation should be, as I said, just the tightness should be just needed to approximate. We need not tighten it too much. But always remember that there will be edema in this tissue, so that once the edema reduces, there may be loosening. So accordingly, we have to do. And this is if the injury is too extensive, then repair as much as possible. If there is a tissue loss, we can use either a fibrin glue or a tissue glue. And as Dr. mentioned already, we can use even the tenoplasty and other things also here. And the scleral wounds along with the corneal wound, then we have to delineate the scleral wound, occur proper hemostasis, then excise all the prolapsed tissue, and then we can use half thickness bites here. We need not go for full thickness as in corneal. That's what we should remember. We can use 9-0 nylon or 8-0 vicryl sutures, and then suture it to the full extent. And if it is going beyond the muscle incisions or beyond the reach, then we can leave them on. And then come to the corneal part, and as usual, clear the anterior chamber from all the unwanted tissue, and then you can address the cataract also at that time. If the anterior capsule is breached, then do a proper vitrectomy. There should not be any tissue incarceration in the wound. And a wound like this is easier to manage because it's only a straight wound, and we have to first fix both limbus, and then in between area has to be covered with equidistant sutures. And so this is a post-op within 2-3 days. The result will be like this. One word of caution: in occult scleral injuries, we have to suspect this whenever there is hypotony, chemosis, and extensive subconjunctival hemorrhage. Then usually the area of breach will be somewhere near the muscle incision or the equator or the limbus. So if you are not able to see, patiently explore, find out the tear, and then suture it as such. So this main aim, especially in case of corneal wound, it is to regain the corneal contour. It's not enough just to suture. If you are losing the corneal contour, then it's not going to be. It's like a plastic surgery. That's what we have to remember here when repairing these wounds. Thank you.
I think this has been a fantastic session covering all the important aspects in management of corneal perforations. I really do thank the audience who sat through with us and listened to our course here. And I thank all my speakers for taking out time and making such excellent video presentations and being with us today. Thank you so much. Thank you, Dr. Samar Basak, as well, for his presence for our wonderful session. Thank you very much, sir. Can we have a quick photograph, please?